It is a great honor for me to present Dr. Ferrari to the talk in the consortium. I'll just read a couple of things about him because he is now the director of the Center of the for Infectious Disease Dynamics. Professor Ferrari is a whole career development professor and associate professor in the biology department at Penn State University, also associated to the statistics department. Professor Ferrari's research focuses on the application of mathematical models and quantitative epidemiology to guide vaccination policy for childhood infections. And for over a decade, he has worked with the World Health Organization, the US Centers of Disease Control and Prevention, and Doctors Without Borders on vaccination planning and outbreak response for measles around the world. Also, well, in a more related to me point, we are Professor Ferrari works in also the strategies to develop surveillance methods for livestock disease spreading in different places, in this case in Turkey and also Kenya and the UK. So Professor Ferrari has been working a lot and for a long time, and it's a pleasure for me to introduce him, and I am not going to talk anymore. Matt, the stage is yours, and thank you very much for your presence here.
Yep, thank you, and thanks for the introduction. I always have to say it again. So my name is Matt Ferrari. It feels very weird to be introduced and not to say your name again. So my name is Matt Ferrari. I work at Penn State, and I've been here a while, working on a variety of different things. The vast majority of what I do and my portfolio is focused on measles and rubella in low and middle income countries. That's what I spend most of my time thinking about. But it's in the context of that I've worked on a variety of different projects, both theoretical and applied, with respect to surveillance for febrile rash disease, the implementation of routine vaccination programs. And so routine, or I guess routine is not quite the right word, preventative vaccination programs. So designed to get children vaccinated before outbreaks happen. And in the case of measles, that can oftentimes be a very complicated thing involving both routine well child visits as well as pulsed community-based campaigns. And I've worked with a variety of organizations and national governments on development and allocation of different strategies for those kinds of preventative vaccination campaigns. And then because the world is what it is, and prevention doesn't always work, we deal with outbreaks, and a lot of the rest of my work in measles has dealt with strategies to respond to measles outbreaks and evaluation of whether or not those strategies have been effective. And it's in that context that I've sort of viewed the world over the last 18 months and the world of COVID-19. I think at various times I have drawn a lot of parallels between COVID-19 in the United States and even COVID-19 here locally at my own institution, and planning for response at my university in terms of humanitarian crisis and crisis outbreak response that I've seen in the past. Some of that might just because that's the lens that I have, so I see everything through that lens. But I do think that at times, because this has been an emerging infection where we can't rely on necessarily existing infrastructure and protocols, where we're trying to learn and adapt and change strategies as we go, that as an analogy has a lot in common with crisis response in general, right? Every crisis is different. and you have to rely on past experience and adapt that past experience to whatever the contemporary setting is. So it's in that context that I've been looking at a bunch of this stuff. So I have a couple of slides that I was going to show. I have a slideshow that has tons and tons of slides in it, which I'm not going to show you all 43 slides that are on here. But I have some of that stuff here as background in case questions come up. And by all means, just stop me and interject at any point. I'm only trying to get through the first 6 of these, and it doesn't bother me if we get stuck at the first one. So let me see if I can just switch this to. Are you guys seeing the presentation on the first chart? Great. So this is the title that I sent when I was asked. And as many things happen, you think that you always think, oh, that's a good title, and then you realize as you start preparing things that maybe your ideas are going to coalesce slightly differently. So this is this was my sort of slightly more hopeful title because I'll admit I'm really tired of COVID. I'm tired of thinking about COVID, and I'm really focused much more on what's next, both for COVID and for the world in general, sort of when we're in this sort of post-pandemic response and dealing with the consequences and after effects of this pandemic. And so again, it's some of this is what's next for COVID and what's next for humanity, et cetera. So in March 2020, I through a series of unfortunate coincidences, I was asked to provide guidance to Penn State University and Penn State administration on the development and planning of their COVID response plan for that spring, and then leading again into fall 2020, 2021, and I've stayed involved in campus planning ever since. And that has been an experience in and of itself. I'm happy to talk about challenges and frustrations of dealing with that. I imagine many people on the call have been involved with other organizations and municipalities trying to organize these things. But I sort of put my, I sort of think about these dealing with infectious disease outbreaks in this context. So the first thing we tend to think about is prevention. So the goal is to prevent outbreaks from happening in the first place. And in the context of COVID, this was many of the first level of things that we're dealing with, especially in the US when numbers were really small. We were talking about use of PPE, education about hygiene, distancing, closing of businesses, et cetera. And these were all cases where we asked individuals to take on individual measures to limit population risk. And so we're trying to encourage individuals to do something to affect a population change. And that's an ideal, but the ability of individuals to take on that change is really has to be couched in terms of infrastructure and societal norms and the structures that we put in place to facilitate that. And so in particular, the infrastructure, I think that was really critical to COVID response had to do both with sort of physical infrastructure for things like testing and monitoring, getting people tested so we knew what was going on, but also information infrastructure. How do we communicate this information to people so that they understand risk, they know risk, and they can make informed decisions and take on those individual behaviors that are critical, right? So infrastructure here ranges from testing sites that are accessible all the way to paid leave, so that you don't feel a cost to getting tested because you don't worry about the loss of wages that you might have, which again can create or exacerbate existing inequities in the distribution of disease, because those individuals that have access to paid time off and can take on individual prevention behaviors can do it, where others are sort of forced. Again, we saw this with essential workers, et cetera, having higher rates of disease, right? So, or higher rates of disease or severe outcomes, right? So prevention and infrastructure, I think, are fundamentally linked, and you have to think about them sort of together. But that infrastructure can be thought of both in terms of facilitating preventive measures, but also facilitating response. One of the things that we found, universally, I've written several papers now that have time is of the essence in the title. It's time is of the essence : something else, right? Is detecting outbreaks quickly always improves the potential for response, right? And so things like testing and monitoring, that's infrastructure that's put in place to keep crisis and response as small as possible. But also, we need to, again, build infrastructure and have structures in place to be able to respond quickly. And sometimes that requires investment in resources that you hope you won't use. So things like isolation, contact tracing, quarantine, these are investments and structures that you have to put in place that you hope you'll never use, right? But they're motivated, and the value of them is motivated by the disproportionate costs associated with the exponential scaling of costs and downsides in the event of an outbreak, because outbreaks tend to have this unfortunate exponential scaling, right? And then we have this nice indirect link between prevention and response, that the more prevention you do, the less the probability of that response is necessary, and the less likely you are to go down this full path, right? So this was sort of the way that I was kind of pitching different kinds of investments to Penn State University and to the other organizations that I was working with at the time. And I just wanted to take a few minutes to talk a little bit about where my background with some of those things came from. So I'm going to start with at the response end, because this is almost chronological. This part is chronological, at least, right? I first got involved in humanitarian response in dealing with measles outbreak response. The first case I dealt with was in the capital city of Niger. It's Niamey. It's a city between about 750,000 people. It's probably much closer to 1 million people now than it was in 2004 when I was first involved. And the case there really highlights, I think, the importance of building infrastructure and pre-positioning response to be able to be effective. So many of the limitations to functional outbreak response are not technological. It's not, so we've had a vaccine for measles since 1964. It's very effective, right? We know how to do it. We know how to deliver it. We have infrastructure. We have health facilities, et cetera. Oftentimes the barriers to response implementation in crisis are logistical and organizational, right? And so we have to work in peacetime to try and break down those barriers. And to give you this specific example of this outbreak, as late as 1999, the WHO policy recommendations for responding to measles outbreaks specifically contraindicated the use of vaccination as an outbreak response strategy. That's not to say that they thought the vaccination wasn't useful. Vaccination is very useful in preventing outbreaks and is very useful as a prophylaxis. However, once an outbreak has started, you've got exponential growth, an outbreak is spreading very quickly. And the presumption was that by the time you deployed a vaccination campaign, you would have taken resources away from treating cases and other preventive measures. And you would then have vaccinated individuals. It would take them some amount of time to develop a protective immune response, and you'd be behind the fire instead of ahead of it, right? And that was the presumption. As it turns out, that presumption was predicated on old analyses that had been done in European settings in unvaccinated populations. And what I did in a project with Médecins Sans Frontières was to update that analysis using contemporary data from Niger to show that in partially vaccinated populations, the outbreaks were much slower, the fire spreads much slower. And then there was operational analysis that was done by MSF to show that they in fact could mobilize resources very quickly, get vaccination campaigns into populations very, very quickly. And actually, because the kinetics were different in these settings, right, that the cost benefit on outbreak response was much more favorable. And so in 2005, WHO changed their policy recommendations and made outbreak response vaccination the frontline response strategy to measles outbreaks around the world, right? So again, this wasn't a technological solution. It's not that we needed a new vaccine. We had an old vaccine, but what we didn't have was the preposition knowledge of the relevance of and the value of doing this. And because of that, we also didn't build the necessary infrastructure to be able to deploy outbreak response in places where they are. Now I work with MSF in a number of places, including DR Congo, to actually be thoughtful about how we preposition responses, how we preposition resources to respond to outbreaks. Because what we can do is we can then, if we look at where risks are, right, we can build up infrastructure disproportionately in places where risks are highest. And so what we've been doing to facilitate that is to establish a system of monitoring surveillance in Southeast DR Congo, this region in the Southeast, which is colloquially referred to as ex-Katanga. DR Congo changed their provincial names and split up from I think 15 into 33 and changed the names of things. But the area in the Southeast is where the French section of MSF works, and they've been responding to measles outbreaks frequently and often over the last number of years. And every year they're there, and every year there's a measles outbreak somewhere, and they're constantly chasing around measles outbreaks and realizing that that perhaps, despite being a crisis response organization, that's their mission. So they don't work in development and infrastructure development because their mission is not development. Their mission is crisis response. They realize that that effectively, by changing their mentality, they said, in fact, this is a whole region that is perpetually in crisis because of lack of infrastructure and inequity in access to care. That's the crisis we're responding to, right? It was sort of an interesting paradigm shift for them. And so in order to overcome that, what they needed to do was to develop information and an evidence base for how to pre-position resources and deploy resources quickly. And so what we've been doing is working on developing a system of sentinel surveillance in this area. And what we're doing is taking models, using those models to figure out where we think risk is highest and lowest, and then building sentinel locations in those places. But what we're doing is we're not presuming that our model is right. Because if we did that, then basically what we're doing is we're taking a lamppost, shining it on the place that we think is the highest risk, and then looking under that lamppost and finding what we find, right? So what we're actually doing is also building in sort of control surveillance sites in areas that we think are low risk, so we can then evaluate whether or not the model-based risk assessment is validated by the empirical data that we're collecting, so that we can then either feel more confident in taking a more riskier allocation strategy, right? The ideal allocation strategy would be to know exactly where the risk will be and only put your resources there, right? That's the ideal, but it's very risky. And so we're trying to build an evidence base to assess that, right? And so, of course, as we kind of build systems like that up, right? The idea here is in fact not to have the best system of response possible, but to create a system of prevention that obviates the need for a crisis response. And so really building up vaccination programs and allocation of vaccination strategies, again, is a passion of mine and a big part of my research portfolio. I want to talk about a really specific case, just briefly talk about a really specific case here that I worked on in 2015 with an organization called Save the Children, which I think is actually really important in thinking about what a post-COVID world is going to look like. And this is specifically in times of crisis and disruption. Local infrastructure and local preventative resources oftentimes get dramatically disrupted. And I think that we're seeing that very much now through COVID. We're seeing a massive disruption in many cases. Both, right, we're breaking social ties and changing cultural norms, right? We're also changing people's interaction with health systems, and we're changing priorities in the short term. And one of those important priorities that we hope for lots of parents is prophylactic vaccination through well child visits for young children, right? And what we've seen is around the world is that many parents have not been taking their children in for well child visits. We've seen an increase in the young child susceptible population for all kinds of vaccine preventable diseases. And there's a lot of concern about the potential for the resurgence of a great many vaccine preventable diseases in the wake of COVID. Which is ironic at a time where we are dramatically expanding the capacity for vaccine distribution, particularly in the U.S., but to a lesser extent around the world. So in 2015, I was contracted to go to work on a project in northern Syria in Idlib province. I actually didn't go to northern Syria. I went to Turkey, right across the border, and was based out of Antakya in Turkey. And this was a setting where a different large-scale humanitarian crisis had dramatically disrupted vaccination programs, and this was the civil war and internal crisis in Syria, where northern Syrian rebels were being shelled by the Assad regime, and particularly this was happening in the region around Idlib province. Of course, because I'm speaking right now, I've lost the name of the town, the big town that's right next to it that was in the news all the time. But I'll shout it out in a few minutes. So there was a large city that was the focus of a lot of international attention. And what was happening was as people were fleeing from that region, they were moving to the next large city over, which was Idlib. That was at that point drawing a lot of now new attention from the Assad regime, and they were increasingly shelling that area. Syria, prior to the Syrian civil war, had very, very high routine vaccination coverage. Had really a really stellar childhood preventative program with really, really high rates of well child visits. But because of the Syrian diaspora, now millions of people and millions of children were going without routine vaccination. And what we had to do was to then look at how we build back a very complex health system. And this required a very thoughtful look at what priorities were. Of course, we want to build back polio, diphtheria, tetanus, measles, rubella, varicella, all of the vaccines that were in the routine program in Syria, we wanted to put back immediately, right? But we couldn't do everything all at once. And what I did was working through a variety of partners, trying to build coalition on what the response should be. And we looked at two options. One that was to try and take a small number of places and build back the full preventative vaccination program in a small number of places, or take all locations and try and just reinstate some portion of the system, right? And what we ultimately decided was it was the latter case that was the recommended strategy. And specifically what we would do is we would prioritize the antigens, starting initially with measles and polio. So measles shouldn't surprise you because I'm super biased. So of course it was going to be measles. But the reason that we prioritized measles was because it is so infectious. The R0 is so high. And so we basically had some time to lose, right? So we could let diphtheria and tetanus, et cetera, immunity drop a little bit before a crisis would happen. But the canary in the coal mine, the first response, the first additive crisis was going to be due to measles. right? So that was what put measles at the top of the list. Polio is at the top of the list, not so much because of the risk of polio in Syria itself. It's a comparatively rare disease. It's eliminated from Syria right now, and has a lower R naught, so was unlikely to cause super dramatic outbreaks, but because the world was so heavily invested in polio elimination and eradication, this was perceived as the potential for loss of ground in Syria was perceived at such a would manifest in such a large global cost by now introducing a new location that where potentially polio could reestablish, that would now necessitate huge new additional investments in an already challenging environment. That we got built better coalition had stronger investment from partners who are much more willing to work on the measles component of this, so long as we also included polio in the system. And so again, this was a trade-off between both epidemiological concerns and operational, logistical, and diplomatic concerns building this back up. All right, so prevention, infrastructure, and response, right? I mean, these I think are the three key core areas. Prevention is costly and often imperfect, and we need to really think about how we balance the needs of prevention against operational and logistical constraints. Infrastructure is what allows systems to work and individuals to behave safely, and again, infrastructure is also costly, and so we need to, in some sense, to build evidence and the collection of information to develop an evidence base into infrastructure planning. And lastly, we as part of that, right, we need to consider not just the infrastructure for prevention, but also the infrastructure necessary for response. And oftentimes we need to make investments that we hope we won't use, but the critical downsides of failing to make that investment can dramatically outweigh the costs of the limited costs of investment and response overall. So I've said measles and polio multiple times, but really I think that, again, this is the perspective with which I've looked at the investments that are necessary for planning for COVID as it moves from a global pandemic to what I presume will be much more of a series of localized epidemics over the coming years. So we're actually more likely to move into this preparedness and outbreak response regime. And I think also it's a critical viewpoint for how we should prepare to build up preventative health systems in response to the disruption that COVID has provided on its own. So I don't know if so I'm going to end it with that, and I don't know if you guys can hear that my brand new puppy has been making a bunch of noise in the background. She just got spayed yesterday, so she has the cone of shame on, and this is a really miserable time for her. And so I'm trying desperately to keep her from overstressing herself in the background. So that's why I keep leaning left and right, but she's tied to my waist. And I'm happy to take questions or move the camera so you can see her or whatever.